Hello and welcome to the 2012 San Antonio Breast Cancer Symposium. My name is Skip Burris and I'm here with Bill Gradishar and Hope Rugo to discuss some of the presentations from today. We had some update on the use of adjuvant Trastuzumab, some trial results. There's been some ongoing, very large studies that have looked at what's the appropriate duration, and we got to see a little bit of updated information on those clinical trials at this meeting. Hope, your thoughts on the HERA and the FAIRY trials? Maybe we can take those in sequence?
Yeah, I mean, it's actually really interesting data. We've waited so long for it. And you know, patients were randomized regardless of any fancy markers or extent of disease. So you could have been randomized if you had a 2.2 centimeter node negative tumor or if you had a multi-node positive tumor. So the first question was, is longer duration of Trastuzumab better? And that's the HERA trial, one arm, but the HERA trial looked at 2 years, one arm 1 year and one arm no Trastuzumab. We know that Trastuzumab is better than none, but 2 years wasn't any better than 1 year in the group as a whole. And in fact, we all knew that because they hadn't presented their data yet, so they didn't have enough events. So Trastuzumab makes a big impact. It's not clear that continuing it for longer in patients with early stage disease makes any difference. It's possible that there are some subsets that would benefit that we didn't explore in that trial, but I don't think we'll ever really get to that question. Because
is there a patient, have you ever gone past a year in a patient for a reason?
I have.
You have?
Yeah, these are patients who had, positive margins or, 45 positive nodes, et cetera, but, those patients really are sort of borderline metastatic. One of them is now out 10 years, so I'm going to have to stop the Trastuzumab at some point, which I decided was 10 years. But I think that we do cure a lot of these women, and sometimes the patient just has such high-risk disease that you don't feel comfortable, and neither does the patient, but we really have no data to support that longer duration with. A bigger problem and indeed what we're going to be doing for these patients, I think, in the future is using combined targeted therapy against HER2 with Lapatinib and potentially Pertuzumab in the future. So TDM1 is rescue, who knows, so that we probably aren't going to be extending out the duration. The sort of other side of this question, the sort of American approach of longer must be better, but it was done in Europe, the HERA trial. But most of the countries in the world can't give very much Trastuzumab because it's very expensive, and many were only giving 9 weeks. But so the FAIRY trial looked at, in France, looked at 6 versus 12 months and showed that 12 months was arguably better. And I think that, it's interesting that duration question should be so clear that where did we get a year from? It was picked out of a hat. Right. But shorter may not be enough for many patients with HER2 positive disease. So I think it encourages us to use the longest amount of time you can afford within that first year. And a year seems to be optimal.
Bill, the results change your thoughts on practice, or is there a patient you'd go longer or shorter?
No, I've never used Trastuzumab beyond 1 year. And I think the question about shorter durations, I think at the moment we should stick with 1 year. I think that's the message that people in the community should abide by. But we do have a number of other trials that are still pending that are looking at this shorter duration question. And this is going to be, obviously, as Hope already pointed out, a critical issue in resource-challenged geographies around the world. And something is clearly better than nothing. So some duration of Trastuzumab in these patients should be tried if it's attainable. But at present time, 1 year is what I would give.
Do you ever have a low-risk patient where you would give them the Trastuzumab alone and no chemo, or Trastuzumab and the hormonal therapy?
I have done that, and there are patients where I hope that my recommendation for chemo Trastuzumab is refused on the chemotherapy part. But part of the issue is, the approval was a partnership with chemotherapy, right. So sometimes you run the challenge of actually being able to give Trastuzumab as monotherapy or even with endocrine therapy. But I'm personally convinced, it's a bias supported by nothing, that a lot of those patients would do just fine with Trastuzumab alone, or if they are ER positive with endocrine Trastuzumab. They wouldn't need chemo.
Hope, anything you do unusual or different for certain patients?
For the older patients, you have bad HER2 positive disease, ER positive, and you can't give chemo. I've given Trastuzumab and hormone therapy, but I only give a year of Trastuzumab. And in those patients, it's been successful, but it's possible that they somehow fit into a profiled group that was going to do well no matter what you did. It's hard to know, but certainly I don't feel bad about sparing them the toxicity of chemotherapy. Do you ever give that approach, and do you use more than a year of trastuzumab?
You brought up the case where you've got the patient who you just intuitively has metastatic disease, be it the volume of disease, lymph nodes, or their presentation. And so we've had some patients that were in that sort of setting that have continued on. I've pushed patients to take a year. I've done hormonal therapy alone. We participated in the trial that gave just the weekly paclitaxel, which is thought to be consideration.
That was a great study.
It's a great study, and I think
Look
that
forward to the results.
we're in a difficult situation with adjuvant trastuzumab because now the duration question has been answered, and I think no surprise from those results. How can you, with the success we have, how do you bring new regimens into that? It's almost the testicular cancer scenario where you're doing so well with that group now. How do you get to something that might be cooler, less toxic, less to give, and hopefully we'll put some energies behind those trials.
I love the trial that Dana-Farber has, in a new trial that a lot of the people who participated in the weekly paclitaxel for 12 weeks with a year of Herceptin did, which will randomize now the ATTEMPT trial to the same 12 weeks of paclitaxel and a year of trastuzumab versus TDM1 followed by trastuzumab. And that, I think, is also a very interesting study. The randomization is good. It's specifically for small HER2, so the patients we really struggle over now. Maybe some of them didn't need any of that, but I think it'll be quite interesting.
There was a trial that looked at the angiogenesis inhibitors, again, much discussed in breast cancer, the LEA trial.
Yes, and also Beatrice. So Beatrice in triple negative disease, and the LEA trial as first-line therapy for metastatic ER-positive, HER2-negative breast cancer. And the Beatrice trial, disappointing results. I'm hopeful that biomarkers will give us some information, but didn't show any benefit with the addition of Bevacizumab in triple-negative disease. And maybe that's because the group is so heterogeneous that really we still have no idea who benefits from Bevacizumab, and that trial didn't help us any. And then the LEA trial, I think, really is an issue of endpoints and not meeting the pre-specified endpoint, although a glimmer of possible benefit. There is a CLGB 40503 that should report, I hope, next year. Maura Dickler is running that trial that is looking at the same trial design, so that'll help us have some information. And we're also hopeful that they may be able to combine the two groups of patients to look at the results, which I think will give them more power.
Bill, any thoughts on Bevacizumab or other angiogenesis inhibitors, and are you bringing it into your practice for any patients?
Well, we still do use selectively Bevacizumab in patients with metastatic disease, usually first-line therapy, sometimes younger patients with the taxane. And I think, though the results with some of the studies that Hope just described are a bit disappointing, I don't think it kills angiogenesis strategy, but I think there are a lot of other drugs that still have an opening here that we're looking at. Small molecules, antibodies, other things. So I don't think it's dead yet. The final chapter isn't written on that.
Anything else from today's presentations? Any thoughts on the biologic antibodies, on Trastuzumab, Bevacizumab that you'd like to bring to the audience?
Well, the only other additional thing that was discussed was the Cleopatra study, which we know was the first-line therapy with the addition of Pertuzumab to Trastuzumab and docetaxel, which was reported previously showing that the doublet of two antibodies significantly added an improved outcome. And another biomarker study that basically confirmed the best way of determining who's going to benefit, you got to be HER2 positive.
Hope, anything to add?
There's some also additional data looking at immune markers and response, et cetera, but nothing that we're really ready to jump out and decide about treating patients about or not. And most of what we do with these biomarkers is figure out who benefits, but we don't know what to do with the people who don't benefit. We're not finding out who benefits from, say, the addition of Pertuzumab or something like that. We're not quite there yet.